PCOS and infertility. What scientifically supported steps can you take to manage PCOS and improve your fertility? Hello, friends. I'm Dr. Emma Mary. As a fertility specialist, I discuss this topic every single day in my practice, and there's an overwhelming amount of misleading information floating around online. That topic is PCOS. Today, I'm going to walk you through several evidence-based strategies you can actually use, separate fact from fiction, and highlight what is genuinely backed by science. So, expect to get all the essential facts in this video. A few important points before we jump in. Thank you so much for being part of this community. As always, this channel is created for you, and I truly love watching it grow. So please take a moment to subscribe, share this video, leave a comment, hit the like button, anything that helps spread this valuable information to more people. Thank you so much for supporting this channel, and now let's dive right into our discussion about PCOS. When we talk about PCOS and how to treat it, we first need to establish a foundational understanding of what PCOS actually is. I've encountered so many different theories about the root causes of PCOS, so I believe it's crucial that we start from the same page. Here's the way I like to explain it. Imagine your ovary contains a vault where all your eggs are stored. At the beginning of your life, that vault is completely full. Throughout your lifetime, eggs gradually emerge from that vault. Each month, a group of eggs comes out. Each egg develops inside a follicle, and the brain releases FSH, or follicle-stimulating hormone, a very appropriately named hormone that signals one follicle to grow. As that follicle expands, the egg matures. The rising estrogen level from the mature egg alerts the brain that the egg is ready, and then the brain sends out a surge of LH, or luteinizing hormone. That initial LH surge causes the follicle to rupture, releasing the egg. This is ovulation. Afterward, the follicle transforms into a cyst called the corpus luteum, which then produces progesterone throughout the luteal phase, driven by LH pulses from the brain. That's the normal process. So, what goes wrong in PCOS? There are several ways to understand it, but one of the most helpful perspectives is this. In PCOS, you have a higher than average number of eggs. That might not sound like a bad thing, and it's not necessarily negative, but because the communication line between the brain and the ovary is disrupted, they essentially can't see each other properly. The brain doesn't realize the ovary has an elevated egg count. What happens is that the brain releases a normal amount of FSH, but that FSH gets spread thin across all your many follicles. As a result, the signal isn't strong enough to make one egg grow reliably and predictably. This leaves you stuck in the follicular phase, the early part of your cycle where estrogen remains relatively low. You don't produce progesterone because you haven't ovulated. Essentially, your ovary isn't putting out large amounts of estrogen or other hormones. Here's a very important side note. A fully mature egg produces about 200 picograms of estrogen. Each immature egg, by contrast, produces roughly 1 picogram. Because you have more eggs than the average person at baseline, you also have slightly higher baseline estrogen. For instance, if a normal baseline estrogen level is 20 picograms and you have PCOS with double the number of follicles, your baseline might be 40 picograms. You might be told you have estrogen dominance. Again, this is simply a slightly elevated baseline during the follicular phase. A core part of the problem is that you're not ovulating. Two things then occur. The brain sends out normal FSH, but it's diluted, so it takes much longer for you to ovulate. Meanwhile, the ovary gets bored and starts churning out, you guessed it, testosterone. Now, the pathway from brain to ovary to testosterone becomes very active. This leads to those classic androgen signs, high blood levels of androgens, as well as clinical symptoms like acne, unwanted hair growth, male pattern baldness, and abdominal weight gain. This, in turn, alters your metabolic profile. Due to the elevated testosterone, you experience a metabolic shift. Lower effective estrogen, higher testosterone. Suddenly, you're dealing with increased inflammation and insulin resistance. You become trapped in a cycle that's hard to break because your baseline estrogen is a bit higher from having more follicles. The brain doesn't get the true signal that you're not actually ovulating. It sees that estrogen level of, say, 40, which is just enough to prevent another signal from being sent. This can be incredibly frustrating and difficult to manage. The way I always describe PCOS to my patients is as a delicate state of hormonal balance that can shift from day to day and month to month. That means one month might be perfectly normal, and then you experience stress, less sleep, or an illness, and everything changes. Or you might release a higher or lower number of eggs from that vault, because we know the vault isn't perfect, so unpredictability is actually a built-in feature of this syndrome. Okay, one last piece before we move into treatment. Remember how we diagnose PCOS? It's based on 2 out of 3 criteria, known as the Rotterdam criteria. First, a high egg count. Second, any clinical or laboratory signs of high androgens, those testosterone-related symptoms I mentioned. Third, irregular or absent periods. Having just 2 of these 3 qualifies you for a PCOS diagnosis. Now, when we think about treatment, our goal is to reverse this cycle. We want to lower inflammation and reduce insulin resistance. Keep in mind that insulin resistance is a major driver of inflammation. So, if someone tells you inflammation isn't important for fertility, they simply don't understand the link between insulin resistance, inflammation, and the full picture of PCOS. Ideally, if I can help you ovulate, this will naturally reverse some of the issues. But obviously, we need to work backward, especially if you have a high egg count. I also want to add a disclaimer. Some people can follow every single recommendation I'm about to give and still need fertility treatments, and that is perfectly okay. We have 3 layers of intervention: lifestyle changes, supplements, and fertility treatments. It's not a failure if you end up needing those medical options. Let's talk about lifestyle first. Number 1, reduce inflammation through daily habits. The first step is to sleep at least 7.5 to 8 hours per night. Put your phone in another room. Create a restful sleep environment. Sleep is when your body repairs inflammation. Without adequate sleep, you're not setting yourself up for success. Number 2, gut health. We cannot underestimate how much the gut influences what enters your body. Your gut health is directly tied to your inflammation levels. We need to consider things like gut permeability and the gut microbiome. These are extremely important. The gut metabolizes estrogen. We want your body to efficiently metabolize estrogen so that your brain can potentially sense a lower level. That means healing the gut lining. Many people develop what's called leaky gut from chronic inflammation caused by toxins, processed foods, insufficient fiber, or changes in the gut microbiome. So, what provides fiber? Plenty of fruits and vegetables. That should be the core and bulk of your diet. Lots of produce. We also need healthy fats because fats and cholesterol form the backbone of all steroid hormones. So you must give your body fat to produce hormones. Additionally, include good protein sources. And we really want to cut down on excess added sugar, artificial sweeteners, and ultra-processed foods. Those are the most important things to reduce. As we begin healing the gut, we can often reintroduce food groups that are commonly eliminated, such as dairy and gluten. In the fertility formula, I discuss how to add them back in and retest your gut once it's healed. Research shows that every serving of plant-based protein compared to animal protein correlates with an increase in ovulation among women who experience irregular ovulation. So, is it safe to be entirely plant-based? Yes. Do you have to be? No. But every small choice you make in that direction is beneficial. You absolutely do not need to follow a no-carb diet or enter ketosis. Those approaches are not proven to help with PCOS. When it comes to exercise, your specific goals may depend on your weight and whether you're trying to conceive. But the key principle is to build muscle. Skeletal muscle helps your body combat insulin resistance. Remember, we're trying to reverse this cycle. So how do you build more skeletal muscle? Not by spending hours running miles or cycling endlessly. Instead, focus on resistance and strength training using your own body weight. Do something every day. It doesn't have to be high intensity, just consistent. Also, think about ways to lower stress and reduce exposure to environmental toxins. Number 2, in our overall approach, consider supplements that are evidence-based. Here's what I recommend for anyone with PCOS. First, vitamin D. You need at least 1,000 IUS of vitamin D daily. Many prenatal vitamins contain it, but not always, so check the label. Vitamin D supports hormone balance and ovulation, and we know that women with PCOS tend to have lower vitamin D levels. Second, omega-3 fatty acids. These are also crucial if you're trying to conceive, as they support baby's brain development, and they are highly effective at reducing inflammation. Third, inositol. I like inositol because it helps improve insulin sensitivity, meaning your body becomes less insulin resistant, responds better to those signals, and thus supports ovulation. And of course, if you're trying to get pregnant, take a prenatal vitamin with at least 400 micrograms of folic acid. Now, regarding medical treatments, metformin is an option if you have irregular ovulation or insulin resistance. Metformin can be highly effective and has been proven on its own to help improve ovulation. Beyond that, many people require what's called ovulation induction, which can be done with either Clomid or a medication called letrozole, also known as Femara. In fact, letrozole is the drug of choice for PCOS patients. How does it work? It reduces estrogen levels in the peripheral tissues. Given that you have a higher baseline estrogen, taking letrozole lowers that level. Then the brain says, "Oh, I don't have an egg growing. I need to send out a stronger FSH surge." The idea is to encourage that egg to grow earlier in the cycle, shorten the follicular phase, and establish a more regular ovulatory pattern. We often see problems with progesterone production in ovulatory dysfunction because the follicle becomes the corpus luteum. So I frequently support patients with progesterone as well. I don't like using progesterone alone. I prefer it in combination with ovulation induction, as that's typically the most advantageous approach. But before you start ovulation induction, I always think it's essential, regardless of your age or goals, to undergo a complete fertility evaluation. Some people say, "You're not ovulating, so let's fix that and handle infertility later." But you'd be surprised how often I see someone who has tried that for 6 months or more, only to find out later that there's no sperm or their tubes are blocked, meaning they were never going to conceive with that treatment, and it feels like wasted time and money. So let's set ourselves up for success. Before starting ovulation induction, get the full fertility workup: 2-ball anatomy assessment, an ultrasound, complete blood work, and a semen analysis. Sometimes you may need IVF, and that is not a failure. Needing any fertility treatment is not a failure. I often say that ovulation induction involves some trial and error to find the right dose that makes you respond. But if you need IVF, you have a large number of eggs to work with, so you're already starting from a great position. However, it's not all about egg quantity. Egg quality matters enormously. Inflammation and insulin resistance contribute to poor egg quality, especially through that metabolic factor. So, as you work to mitigate, manage, or control your PCOS to the best of your ability, focus on reducing inflammation and improving insulin resistance as your starting point. For many patients, that alone leads to natural ovulation, but many still need help from a fertility specialist to optimize the situation. It's not necessarily about fixing your ovulation in isolation. It's about reaching a better state where your brain and ovaries can communicate more effectively. Please let me know in the comments if you'd like a video focused on IVF or other fertility treatments for PCOS, or any specific questions you have, because I know PCOS can be incredibly confusing. Don't forget to check out some of those other episodes. Thanks, friends!